Please, good afternoon once again. I believe you can hear me. Please, good afternoon.
Yes, good
Yeah, good
afternoon.
afternoon.
Okay. I believe we are doing very well.
Yeah, we are very well.
Much for making time to join our NCLEX review. So let's Achievers Friday. Every Friday, we meet and we have a review of a condition for the NCLEX. And in fact, we actually select conditions that you can get quite a number of questions in the Q bank, which means that conditions that you're also likely to get quite a number of questions from on the NCLEX. So last week we met and we did the tetralogy of Fallot. And after the session, we also added an assessment on the tetralogy of Fallot, a 30 set questions on the tetralogy of Fallot from different Q banks. So we believe learning or studying in this fashion actually help build content. So please, let's mute ourselves, please, if you are not talking, please. Yeah, so if you have not listened to, or if you have not watched our the last week's recording on the tetralogy of Fallot, and if you have also not done the assessment, we would entreat you to also visit our page on Telegram and have access to the recording and also have access to the assessment and do it as well. So after this session, we are also going to send, we are going to share a link for an assessment on sickle cell disease stroke anemia from the various skill banks. So that is one of the things that we're going to do after the session. So it's very much important that we all move alongside, we all move at the same pace. So just a little introduction. My name is Sajah Fati, and I happen to be the team lead of Achievers Nclex-Rn Consult. And we actually do private tuition, 4 months tuition. We go through all the key NCLEX areas, not just going through the areas. We also solve questions alongside, and we look at the key specific NCLEX point as well. So we believe NCLEX is all about content. So once your content is very strong, you'll be able to nail the NCLEX, because if you learn the condition and you actually build your content, no matter how the NCLEX will twist the question, you'll be able to figure out that, oh, this is the wrong answer and this is the right answer. So you can join us on our private page. That is our tuition, 4-month intensive tuition. We cover everything. So if you're very much interested in it, you can send us an email or you can visit our website, www.achieversnclassrn.com, and you can leave us a message on the website or you can chat us directly on the website. So that is something brief. And with me, I think Aaron, my team members, let me see if my team members are around. Aaron Nadoma, Aaron Lily, and Aaron Abai. I think they will be joining us very soon. So we would not want to waste much time. So I want to start right away with the sickle cell disease stroke the anemia. So that is what we're coming to look at today. Sickle cell disease stroke the anemia. So we are going to look at two things: the sickle cell trait or the disease, and we're also coming to look at the anemia that is associated with the sickle cell. So that is basically what you're coming to consider today. And I believe at the end of the discussion, you shouldn't get questions on SCD wrong on the NCLEX. So please, let's start right away. In our practice, sickle cell disease is one of the common conditions that we manage in practice, because the sickle cell disease actually is very, 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 very common, because one in every black American would have the sickle cell disease. So in terms of practice, we manage quite a number of cases of the sickle cell. So it's not something that is new to us. We've managed SCD cases severally in practice, and I believe we've all managed such cases before. So what I thought is the sickle cell disease. So let's look at the sickle cell disease, and you look at the anemia aspect as well. So what I thought is the sickle cell disease. We are very much aware that the sickle cell disease, it's genetic. So let's build the point gradually. So the first point that you say is that it is genetic or it is hereditary. hereditary. So we are building up the point gradually. So sickle cell disease is genetic or hereditary. So in this condition, what we are having is that we are having an abnormal, so the keyword is that we are having an abnormal hemoglobin, abnormal HB on the red blood cell. We are very much aware that red blood cell is one of the many blood cells. We have the white blood cell, the leukocyte, we have the platelets or the thrombocytes. You also have the red blood cell. So within the red blood cell, you can find the hemoglobin, the heme aspect of the red blood cell. We are very much aware of the function of the hemoglobin. So the hemoglobin, largely, its function is that it has an affinity to oxygen. It is a hemoglobin part of the red blood cell that will bind to the oxygen. So it means that hemoglobin is very, 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 very much important, very, very much important within the red blood cell. So when we are having the sickle cell disease, what is happening is that we are having an abnormal hemoglobin. So the hemoglobin that is within the red blood cell is abnormal. So if you are saying that the hemoglobin has an affinity of binding to oxygen, so if it binds to oxygen, it means that it can help to deliver or to carry out oxygen to the tissues that are in need of oxygen. So that is one of the functions of the hemoglobin. So it means that a patient or a person who is affected by sickle cell disease would have a problem with this function of the hemoglobin. Aside that, the hemoglobin also has other functions of it's impacting the red color to our blood. It impacts the red color to our blood, but then that is not our focus. Our main focus is the key role of the hemoglobin, that is having the affinity of binding to oxygen and delivering the oxygen to the various tissue or the various organs. So that is what we want to consider. So when we are having the sickle cell disease, we are having an abnormal hemoglobin on the red blood cell. We are very much aware that the normal red blood cell, so this is the normal red blood cell. We can look at the structure or the shape of the normal red blood cell on this very flyer. The normal red blood cell is disc shape. It's a disc shape, and it is very flexible. So the normal red blood cell has a disc shape and is very flexible, and its flexibility allows it to pass through the blood vessels easily, So the shape of the normal red blood cell is very good. It helps in its passage through the blood vessels very, very, very easily. But in sickle cell disease, because we are having an abnormal hemoglobin within the red blood cell, it changes the appearance of the red blood cell into a shape of a crescent, shape, or what we call the sickle shape. So that is what happens. The normal red blood cell is very flexible, disc shape, but then the red blood cell in the sickle cell disease is crescent, or it has a sickle shape, and it's as a result of the defective hemoglobin or the mutated hemoglobin. So that is basically what happens when we are having the sickle cell disease. So this appearance of the red blood cell in individuals with a sickle cell, clearly, it will not allow easy passage through the blood vessel. The image on the right, you can see clearly that the sickle-shaped cells can block the blood flow. Because of its shape, it can cross each other and can block the blood flow. So what we want to say is that in patients or in individuals who have the sickle cell disease, the shape of the red blood cell does not allow easy movement of the red blood cell through the blood vessel. So that is one key thing that we need to also pick up. In as much as we talked about the fact that the sickle cell disease is genetic or is hereditary, it is very important for us to identify which trait, because there are several ways that a trait or a disorder or a disease can pass through families, because we are saying that the sickle cell disease is hereditary. In other words, it can pass through families, the family line. So there are so many ways, or there are several ways that a trait or a disorder can pass through families from one person to the other. So we should appreciate the fact that the sickle cell disease is what? It's autosomal recessive. is an autosomal recessive trait. And this is a bonus question on the NCLEX. If you ever get a question on this, the sickle cell disease is an autosomal recessive trait, which is one of the several ways that a disorder or disease can pass through families. Autosomal recessive, we know the other types. We have what the autosomal dominant as well. We have the sex-linked disorders as well. So there are several ways. But for the sickle cell disease, it's what is autosomal recessive. And what is autosomal recessive? Let's go back to medical genetics. We are very much aware that we have 23 pair of chromosome in the body, 23 pair of the chromosomes in the body. So it means that an individual, we have 46 of the chromosome, 46 of the chromosomes. The first 22 pair are referred to as autosomes. Autosome. The first 22 pair is referred to as autosome. And the 23rd pair is referred to as what? The sex chromosome, right? The sex chromosome. So that is why we pick the word autosomal recessive from here. We can pick the word autosome from it. And the autosome, they are the 20 pair of the chromosome. That is the 22 pair of chromosome, or we can say that they are the non-sex 22 pair, they are referred to as autosome, and the 23rd pair, they are referred to as the sex chromosome. So with the autosomal recessive disorder, what it means is that an individual will receive two. So please, let's take note of this. With the autosomal recessive trait, an individual has to receive two copies. So the word is two copies of the defective gene, or two copies of the abnormal gene. Two copies of the abnormal gene must be present before an individual will be able to express or be able to exhibit. It becomes very, very difficult. Aaron, if you kindly mute yourself. So we are trying to establish, or we are trying to explain what the autosomal recessive means. The autosomal recessive, we are saying that for the disease or for the trait to express in an individual, that individual has to receive two copies of the defective gene from the parent. So it means that we have to get one of the defective gene from the mother, one of the defective gene from the father, one from each parent. Remember that we have two copies of every gene, one from each parent. So in the autosomal recessive traits or the disorders, it happens when both copies of the gene is defected or mutated. So that is what we are saying. So for you to have the sickle cell disease, you have to have the two copies of the defective genes. One defective copy from the father and the other defective copy from what? From where? From the mother, before you can have the sickle cell disease. In fact, there are quite a number of autosomal recessive traits. There are quite a number of the autosomal recessive traits. So that is for the autosomal recessive. And as we said, it is one of the many ways that a disease can pass through families. We can have the autosomal dominant. We know what the autosomal dominant is. The autosomal dominant, even if a single gene, a single defective gene or a single mutated gene comes from any of the parents, you'll be able to express, or you would exhibit the condition. Unlike the autosomal recessive, that you have to get two defective or two mutated genes, one from each parent, the autosomal dominant, just one copy of the defective gene, you can exhibit the condition. So there's a difference between the autosomal recessive and that of the autosomal dominant. In fact, on the NCLEX, they come across some conditions of the autosomal dominant. The common ones for the NCLEX are the Marfan syndrome. Marfan syndrome, that is a connective tissue disorder, Marfan's. Marfan syndrome is an autosomal dominant condition. And also this blood disorder, what we call the von Willebrand's disease. Von Willebrand's disease, they lack the von Willebrand's factor, and that they bleed a lot. It is also an autosomal dominant condition. Achondroplasia, it's one of the conditions on the NCLEX. It is also an autosomal dominant trait that's becoming across. So sickle cell disease is an autosomal recessive trait or disease. You have to have two copies of the abnormal gene, one from each parent, before you can have it. When an individual receives only one copy of the defective gene from a parent, we call them what? The carriers, right? They are the carriers. If you receive only one of the defective gene from a parent, you are just a carrier. You are just a carrier. Or in other words, we can say that you are heterozygous. You are heterozygous. But those that receive the two defective genes, we call them homozygous. They are fully affected by the sickle cell disease. But if you have only one defective gene from a parent, you are a carrier, or we can say that you are heterozygous. So that is one key thing that we need to establish as part of our fundamental before we move on. So as we've established earlier, with the sickle cell disease, it's all about an abnormal gene. We know the normal hemoglobin. The normal hemoglobin is the hemoglobin what? The hemoglobin A, which is also known as the adult hemoglobin. The hemoglobin A, which is also known as the adult hemoglobin. So with the hemoglobin A, it's good. That is what we want. But an individual with a sickle cell disease, they have the hemoglobin S. And with the hemoglobin S, that is the abnormal hemoglobin. And one of the bad things about the hemoglobin S is that the hemoglobin S that is in the sickle cell disease, it is very sensitive to low oxygen level. Very, 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 very sensitive to low oxygen level. So once the hemoglobin S is exposed to conditions where we're having low level of oxygen, it changes the appearance of their red blood cell into the sickle shape or into the C shape. And we know the effect. Once you have the C shape or the crescent shape of your red blood cell, it sticks and it can cluster. It can block the blood vessel. And once it blocks the blood vessel, that is why they start to experience the pain, the vaso-occlusive crisis, that aspect will come in. So we will look at it. And one of the bad things about the hemoglobin S is that the hemoglobin S does not dissolve easily in blood. So please, let's take note. The hemoglobin S does not dissolve easily. It does not dissolve easily in blood. It does not dissolve easily in blood. So the hemoglobin S, it is not the ideal hemoglobin. It is an abnormal hemoglobin. So clearly from our fundamental, if the hemoglobin has an affinity that binds to oxygen, a patient with a mutated hemoglobin that is affecting the red blood cell means that they will have a problem in terms of oxygen delivery or the oxygen supply to their tissue. So that is one of the things that we talk about. But then let's ask ourselves, what brings about the anemia? What brings about the anemia? Where is the anemia coming from? We've established the fact that with the sickle cell disease, they have the abnormal hemoglobin. So it can make the red blood cell in a shape of a crescent or a sickle shape. Assuming the shape of the C or the shape of the crescent, it makes the red blood cell very, very, very weak. The red blood cell become very weak. And as a matter of fact, it does not last long. It doesn't last long. What is the normal lifespan of the red blood cell? The normal lifespan of the red blood cell? 120 days, right? 120
days.
Exactly. But an individual with a sickle cell, the sickle cell red blood cell will not last up to 120 days. It will break about 17 to 20 days. 17 to 20 days. So clearly from here, it means that the red blood cell in the sickle cell disease, they break faster. They break prematurely. 17 to 20 days as compared to 120 days. So that is where the anemia comes from, because the red blood cell breaks down easily. It breaks down very, 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 very much easily. And once you are breaking down your red blood cell, or we can say that you are hemolysis, blood, right? The red blood cell, let's say the breakdown. So as you are breaking down the red blood cells, definitely can lead to anemia. So that is where the anemia aspect comes in our discussion. So that is one key thing that we need to identify. Please, let's go back to our autosomal recessive. In fact, questions on the autosomal recessive with respect to pairing, those questions are not so difficult. Let's look at some of the possible or some of the common questions in the Q bank. We've established the fact that the normal hemoglobin is hemoglobin A. In sickle cell disease, they have the abnormal hemoglobin, that is the hemoglobin S. So questions can ask about a mother has the sickle cell disease. Having a sickle cell disease means that they are SS, meaning that the mother is SS, they have the disease. And this same person can say that the father is just a carrier, which means that they are what? AS, they are carrier. We are using the A for the normal hemoglobin and the S for that abnormal hemoglobin. So if you ever get this question, the mother has the sickle cell disease. The father is a carrier. If the father is a carrier, the question asks about what is the probability or what is the percentage that this couple will give birth to a child with a sickle cell disease? Please, what is the answer? We've said that with autosomal recessive, you have to get what? 2 copies of the defective gene, 1 copy from each parent, before you can fully express the condition. Those carriers, they don't fully express the condition. They are carriers. They are not so much affected. But notwithstanding, carriers can pass the genes to their children. But the carriers, they are not so much affected. But they can pass on the gene to their children. So with this question, the mother has the sickle cell disease. The mother is SS. And the father is a carrier, AS. What is the possibility or what is the percentage that they will give birth to a child who has a sickle cell disease?
50%.
50%. Please, we all agree. So pairing, medical genetics pairing, AS. This one would also pair the S, SS. Another pairing, the second one, AS. And we are going to have what? SS. So the SS here means that we have 2 of the SS. And 2 of the SS is the homozygous. So they would express the sickle cell disease fully. And it is half, so 50%. So there is a 50% chance that this couple will give birth to a child who has the sickle cell disease. So clearly, such questions are not difficult. In fact, such questions, we shouldn't spread them on the NCLEX at all. They are bonus questions. If you ever get the question wrong, don't get easy questions wrong. So that is what we want to see. Some questions are actually bonus. Please, let's have a look at this question from a kill bank. Let's have a look at this. Please, I want someone to give the answer in the chat box. You are reinforcing counseling for 2 parents that are preparing for birth for their child. The mother, okay, so basically, I think this is the question that we did. Okay, no, I think this is different. So the mother has a sickle cell disease. So the father decided to undergo the genetic testing to determine if he's a carrier or not. He finds out that he's not a carrier. So it means that the father is okay. He is not a carrier. You tell them that the baby will have how many chances or what percentage chance of having the sickle cell anemia. Please, what is the answer? The mother has the sickle cell disease. So the mother is SS. And the father
0%.
is 0%. Exactly.
0%.
Yes.
So the answer is what? The answer is D. Please, I hope you all get it. Please, if you can't find out that the answer is D, please raise your hand and let's go together, because it will be very painful for you to get this bonus question wrong on the NCLEX. So the answer is 0%. So that is that. So please, if you do not get this first one, please try your hands on this one. And if you don't get this one, you raise your hand and we'll do it together. 2 parents. The father has a sickle cell anemia. The mother is a carrier. Yes, I think we've done this. One is a carrier, one has. So which answer would you going for?
B.
What is it? The answer is option
50%.
B.
50%.
50%. Exactly.
50%. B.
50%. Yes, clearly the answer is 50%. Please, if you did not get 50%, please kindly raise your hand and we would go through together. So the answer is what? 50%. So please, what I want to say is that these questions are not difficult in terms of asking of the percentages. They are not so much difficult. So we've now built our fundamental. So 4 key things that we've said so far. The sickle cell disease is genetic or it is hereditary, and it is autosomal recessive. And we've also established the fact that the mutated hemoglobin will make the appearance of the red blood cell as was a crescent shape or a C shape. And it makes it very weak. So it breaks easily. Within 17 to 20 days, it will break down, and that will result in the anemia. And we've also said that the C shape of the red blood cell does not allow for a smooth movement of the red blood cell within the blood vessel. So that is also one key thing that we've also established in our discussion. Please, before we move on, as we said, being a carrier is not as bad as being or having the full treat. The carriers, they are not so much affected. One of the key things about the carriers, and it is quite interesting, being a carrier, research shows that being a carrier, there is a good side of it. They have some protection against the malaria parasites. Carriers, some form of protection against the malaria parasites. So they are not so much affected with malaria. So that is one of the good side of it. And the whole thing is very, 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 very interesting. You know that the malaria parasites, they usually invade the red blood cell. The malaria parasites would invade the red blood cell. It will rearrange their content. And then the parasites will begin to breed. And they'll produce some proteins that will make the red blood cells so much sticky. And with time, as they are breeding, as the parasite is multiplying, the red blood cells would explode. And once it explodes, it releases the parasite, plenty of the parasite, because within the red blood cell that it affects, it is multiplying. So once the red blood cell ruptures or it breaks down, it releases the parasite. And these parasites are capable of affecting other red blood cells as well. So that is how the malaria parasites, that is how it works when it affects the red blood cell, when it affects you. But then individuals with a sickle cell, the carriers, interestingly, the shape of their red blood cell in the carriers, it affects the parasite's ability to complete that cycle, the cycle of invasion, producing these proteins that will make the red blood cell sticky, multiplying, and breaking down to release plenty of the parasites. In the carriers, their red blood cell is able to affect the parasite's ability to complete the cycle that we talked about. So the parasite would trigger the hemoglobin in the carriers. Once the immune system would definitely come in. We know the function of the immune system. The immune system would come in and clear the infected red blood cell even before they complete the cycle. So being a carrier, it has some form of let me use the word benefit, and that benefit is being able to be resistant to the malaria parasites. Their red blood cell would assume the shape of the sickle, and one of the things that's going to happen is that the immune system will come in and clear the infected red blood cell even before the parasite will complete its cycle. And proceed to affect the so please let's take note of this as well. So then do we diagnose the sickle cell disease, which is also very, very much important in our discussion. We've talked about the fact that it's very common in Black, also in the Black Americans, very, very much common. 1 in 10 of a Black American, they would have the sickle cell disease. So how then do we diagnose this condition? So testing for sickle cell, we can do what we call the prenatal testing. Before. So even before the child is born, we can check, we can do genetic testing, and we can find out that this child may, the possibility of this child being born with a sickle cell disease is high or is there. So sickle cell disease can be diagnosed what we call in utero. It can be diagnosed in utero. So that is the key thing that please we need to establish. How then do we diagnose the sickle cell in utero? We've said that genetic testing, even before the child is born. We can do the chorionic villi sampling, the chorionic villi. we can sample some of the chorionic villi. Even when the child is in utero, what is a chorionic villi? The chorionic villi, we can say that it is part of the placenta. The chorionic villi is more or less part of the placenta. This is the chorionic villi. It's just part of the placenta. Those tiny projection that we see, this tiny projection, that is the chorionic villi, the tiny projection of the placental tissue. That is the chorionic villi. It contains the same genetic material as the fetus. It contains the same genetic material as the fetus. So picking the chorionic sample or picking some of the sample of the chorionic villi, it's the fact that it contains the same genetic material as the fetus. We can examine it genetically and we'll be able to know. Oh, please let me mute you, Aaron. So we can do the chorionic villi sampling even when a child is in utero, or we can even decide to do what we call the amniotic fluid test. We can pick some sample of the amniotic fluid. We can pick sample of the amniotic fluid. And picking a sample of the amniotic fluid, this is usually done 15th to 20th week of gestation. We can pick sample of the amniotic fluid. With the guidance of an ultrasound, we can introduce a needle into the uterus or into the womb, and we can pick some of the amniotic fluid. And once we pick some of the amniotic fluid, we can examine it at the genetic level, and you can be able to find out that this child is the chances that they would have the sickle cell disease is very high. So we can either do the chorionic villi sampling, or we can do the what we call the amniocentesis. The amniocentesis, we can pull some of the amniotic fluid. But usually the amniocentesis, as we've talked about, the chorionic villi, it's done earlier. The chorionic villi sampling is done earlier as compared to the amniocentesis. The chorionic villi, it's usually done around the 9th and the 10th week of gestation or the 10th week of pregnancy. So that is one way that we can use to test whether the child would have the sickle cell disease or not. So that can be done. Another way that we can establish the sickle cell, whether we have the defective gene present or not, we can do what we call the ditonite test. We call it the Sickle Dex. There's another name for it. We call it the Sickle Dex. The ditonite test or the ditonite test. Another name for it is the Sickle Dex. The Sickle Dex. Sickle Dex. So we can also call it the Sickle Dex. The Sickle Dex. Some resources will give you a different name for this very test. We also call it the solubility test. We call it the sickle solubility test. So you can do the sickle solubility test or the sickle dex or the ditonite test. The sickle cell solubility test, one pro or one advantage of this test is that you can get the results very fast, very quick. You can get the results between 3 to 5 minutes. You get the con or the bad aspect of this test is that this test is not going to tell you that the child is AS or the child is SS. This is a quantitative test. It only detects the presence of an abnormal hemoglobin. So please, let's take note. The sickle cell solubility test or the sickle dex, this test, it only tells you that, it will tell you that there is an abnormal hemoglobin present. Only. It will not tell you that you are AS or you are SS. It will not tell you that. So what they usually do is that they will just take your blood sample, they'll put it in the tube, and they would add the chemical. So the chemical is what we call the ditonite. So they will add the ditonite to the blood sample. They will add the ditonite. This ditonite or the ditonite, its function is that it helps the red blood cell to break down or to lyse. It makes the red blood cell break down. So just take your blood sample, just put it in the tube. We put the ditonite in the tube as well, the tube that contains the red blood cell. The ditonite would make the red blood cell break down. And now we are going to see whether the hemoglobin would dissolve easily or not. We've established the fact that the sickle cell, they have the abnormal hemoglobin. And we said that that abnormal hemoglobin, it does not dissolve easily in blood. It doesn't dissolve easily in blood. So when we do this ditonite test, it is just a solubility test. We want to add the ditonite to the blood sample so that the red blood cell will break down. Then we find out whether the hemoglobin would dissolve or not. So these tests will not tell you that, oh, this child is AS or SS. It will not tell you. So that is why we will do the diatonic test. So you realize that if an abnormal gene is present, the hemoglobin will not dissolve easily. And as a matter of fact, the blood sample becomes very, very, very cloudy. It will become very cloudy, And that is what they use to determine that an abnormal hemoglobin is present. It will become very cloudy. The blood sample become very cloudy. That would indicate that it is not dissolving within the blood. That is why the blood sample is cloudy. So the summary is that the diatonic test or the Sickle test is a solubility test, and it is quantitative. It only tells that there is an abnormal hemoglobin. It wouldn't tell you that you are ES or you are SS. So if you want to know the actual genotype, that is where we do with test, the HB electrophoresis, right? The HB genotype. So we can do the HB electrophoresis, and it will be able to tell us the difference, whether the patient is SS or the patient is ES or the patient is AE. So this diagnostic investigation can actually help us to establish our diagnosis of the sickle cell disease. So that is one area that we need to also take note. I've seen a question in the Q bank that asks about why is it that in the life of an infant or a newborn, let me use the word a newborn, in the life of a newborn, it is very, very, very difficult for the newborn to experience crisis. So for instance, if a newborn has a sickle cell disease, within the first 4 months, the first 4 to 6 months, it's very difficult for them to experience in the newborn with a sickle cell disease. The 4 to the 6 months, very, very difficult for them to have the crisis. Why is it like that? Aris, please, anyone? Why is it like that? I've seen a question in a Q bank. Just what I asked, like a question of it in a Q bank. Why is it difficult, or why is it that the possibility of having a crisis in a newborn and an infant from birth to 6 months, very, very difficult for them to have the crisis? Why is it so? Please, anyone? Why is it so?
With the newborns, they have an HbF, which is a fetal hemoglobin. That is very difficult to break down, causing them not to have or experience the crisis.
Exactly. We are very yes. What Aaron said is that in the newborn, they have what we call, if a child is in utero, if a baby is in utero, their hemoglobin, they have the hemoglobin F. We know the various types of the hemoglobin. It is not only the hemoglobin A, it is not only the hemoglobin S. We can have the hemoglobin F as well. We have the hemoglobin F. The hemoglobin F is what we call the hemoglobin F. We call it the fetal hemoglobin. That is the hemoglobin F. So what happens is that when a child is in utero, they have the hemoglobin F, and we call it the fetal hemoglobin. So God in his own wisdom has given the kids this hemoglobin F, and the hemoglobin F has a higher affinity to oxygen, very, very high affinity to oxygen. So probably, the cause of the pregnancy, the mother may have some condition that would decrease the supply of oxygen to the child. So God in his own wisdom has given them the hemoglobin F. It has a very high affinity to oxygen. So when a child is born, the hemoglobin F is now replaced by the adult hemoglobin. The hemoglobin F is a fetal hemoglobin. We have several types of hemoglobin. We have we can have hemoglobin C. We can have the hemoglobin A. We talked about the hemoglobin A. We can have the hemoglobin S. We talked about the hemoglobin S. So a whole number of hemoglobin, and its formation depends on the combination of the alpha chain, the beta chain, and also the gamma chain. The combination gives rise to the various hemoglobin. So a key point is that sickle cell crisis is not usually seen in the first 4 4 to 6 months of the life of a baby or a child with a sickle cell disease. And the reason is that they have the hemoglobin F. So after 6 months, the hemoglobin F will be replaced. You are out of the uterus. So at that time, from the 6 months, the hemoglobin F, which is the fetal hemoglobin, will be replaced by the adult hemoglobin. So that is why having the crisis is very difficult, because the hemoglobin F, it prevents sickling. The hemoglobin F prevents sickling. So within the first 6 months, it will be very, very difficult once the hemoglobin F has not been replaced by the hemoglobin that they have to actually get. So that is one thing that we have to. So once we get that question, the answer is that because within that time, they have the fetal hemoglobin, it has not been replaced by the adult hemoglobin. So that is why having the crisis in these babies or in these kids, it's very, 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 very not so common between the 4 to the 6 months of life. So that is one key thing that we need to talk about. So probably we've seen some other variations of the sickle cell traits. Somebody can be AC, somebody can be SC. The S, the A, the C, they are all hemoglobin. They are all hemoglobin. So somebody can be AC. There are some variations of the hemoglobin, some variations or some mutation. So somebody can be AC. Being AC would mean that you have the A, which is good, which is the normal hemoglobin, but the C, it's a mutated one. So being AC, your tendency of having episodes of the sickle cell disease is very, 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 very low as compared to somebody who is SS. Same as somebody who is SC. SC, they can have crisis, but then the tendency or the possibility of having the crisis as compared to somebody who is SS, it's quite lower. So the SC, the AC, they are all combination of the various hemoglobins. So that is one thing that we need to also establish. So clearly from our discussion, we've seen that one of the effects that is going to be seen is that the patient would have an imbalance in terms of the oxygen requirement and oxygen delivery, the oxygen requirement by the tissues or by the organs and the delivery. If the red blood cell assume the shape of a C, do you think that to be able to really bind to oxygen, the answer is no. So there's going to be that imbalance. So that is one key thing that we need to establish. And this defective gene that leads to this abnormal hemoglobin, in fact, it can lead to a whole lot of issues. Individual with a sickle cell disease, they can have a whole lot of issues. And going forward, we talk about these issues. They stand at a risk of infection. They stand at a risk of anemia. We've talked about why they stand at a risk of having anemia. They can have severe pain, largely due to the vaso-occlusive crisis. We talk about this, all of this. They stand at a risk of having a lot of issues, a lot of complications. They can even have a stroke.
And the prolactin. Yeah.
Sorry, let me mute Aaron. So they can even have a stroke, and a sickle cell disease patient, they can even have a stroke. They can have acute chest syndrome. They can have what's called acute chest syndrome, which is life-threatening. They can even have a myocardial infarction. We'll talk about all of this. And as we move on, you appreciate why they would have all of these complications. They stand at a risk of priapism as well. Prolonged erection, priapism. They stand at a risk of a lot of complication. They can have reticulocytosis. Reticulocytes. What are reticulocytes? Immature red blood cells are referred to as reticulocytes. They can have a lot of immature red blood cells. Why would they have a lot of immature red blood cells? They are breaking down their red blood cells. Their red blood cells are breaking down easily. Once the red blood cell breakdown, the bone marrow would compensate. The bone marrow would work and produce more blood cells. As the bone marrow is producing the blood cells, the red blood cells be immature. Plenty of these immature red blood cells. So you can have reticulocytosis. The patient can experience the pain in terms of their growth. They would have a reduced growth. A lot of things. They have a lot of conditions. They can have the pulmonary conditions or the pulmonary complications as well. So going forward, we would look at how all of these issues that we've talked about, how it would come up. So please, let's have a look at this. One of the commonly asked questions in the kill bank in terms of the sickle cell disease through the anemia, it's about their crisis, the sickle cell crisis. What actually brings about that crisis? And these questions, this is a bonus question. What brings about their crisis? Anything that would put stress on their body can bring about a crisis, right? So we can use a very nice mnemonic. You can use a sickle because that is what we are looking at. So what can bring about a crisis? When we are having a significant blood loss, So having a significant blood loss, a patient with SCD, if they lose a lot of blood, they can have a crisis. It's either surgery or trauma. They can have a crisis. It can trigger the crisis. Illness, for illness or infection. Illness or infection can also trigger their crisis. So that is why with the SCD, we are so much concerned about the infection. We put them on penicillin V as a prophylactic treatment. So infection can trigger their crisis. Climbing, if a sickle cell patient loves to climb high altitude, it's a mountain climber or climbs the mountain. Climbing high altitude, we know the effect. As you go up, the oxygen level decreases. So climbing high altitude can also trigger their crisis because you receive less of the oxygen. If they keep continuous stress, it can also trigger their crisis. If they take low water intake, that is dehydration, it can also trigger their crisis. And if they expose their bodies to elevated temperatures, or we can say extreme end of temperatures. So extreme end of temperatures, we want to say that when they are exposed to too much hot environment or cold, both can trigger their crisis. We know the effects of cold. Cold does what? Cold constricts. Cold will constrict your blood vessel. Already they are having their red blood cell the shape of a sickle, and now you've exposed them to cold. We can have vasoconstriction. Do you think that the sickle red blood cells will be able to pass through the blood vessels easily? No. So it can bring about a crisis. What about the hot environment or the warm, the extreme warm environment? If you expose yourself, if you are in a hot environment, what do you think would happen? Hot environment increases your basal metabolic rate, right? Your BMR, your basal metabolic rate. Exposing yourself in a hot environment, you see the effect. You sweat and all. The body demand for oxygen increases if you expose yourself to heat or to environment that is very, very hot. So patient is having a sickle cell disease already. There's a problem with their hemoglobin. There's a problem with their red blood cell. Its ability to bind to the oxygen, it can reduce, as we said. And you are exposing this patient, or this patient is exposing himself to elevated temperatures. Exposing yourself to elevated temperatures or hot environment would increase the body demand for oxygen. And this patient is not having that luxury. So it can bring about their crisis as well. So all of these points can bring about the sickle cell crisis. Even alcohol, a sickle cell patient who takes alcohol can largely cause dehydration. So alcohol can also be a trigger. It can be a trigger of their crisis. Alcohol, even tobacco, smoking can trigger the acute chest syndrome. You come across you talk about the acute chest syndrome. A sickle cell patient who loves smoking, the chances of having the acute chest syndrome is very, very high. It can trigger the acute chest syndrome. So the questions that would ask about the cause of the triggers, definitely those questions should be bonus questions. So we can use the mnemonic sickle to help us recall some of the points that can lead to their crisis or that can lead to the crisis. So fast forward, we want to look at the crisis that they experience, which is also one of the key things that we need to talk about. Important, very, very, very much important we consider this. The crisis. Largely, they have about 4 crises. So we are going to talk about the 4 crises. The first crisis, in fact, we've talked about it already. So we are just going to touch on it briefly and we move on. So they can have what we call the vaso-occlusive crisis. Vaso-occlusive crisis. Vessel, blood vessel. occlusive. So you can pick the word occlude. So clearly it speaks for itself. So that's why sometimes we see patient diagnosis SCD with VOC, with vaso-occlusive crisis, with the vaso-occlusive crisis, and it is the common crisis, very, 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 very common. It is a common crisis. Of all the crises, this is the common crisis, the vaso-occlusive crisis. So with the vaso-occlusive crisis, what happens? We are having, if it is a blood vessel, this is the abnormally shaped red blood cell. It will not be able to pass through the blood vessel very, very, very smoothly. So it can block each other, and eventually it can block the flow of blood within a blood vessel. If it blocks the flow of blood within a blood vessel, what do you think would happen? We're going to have hypoxemia, low level of oxygen supply to the tissue. So you're going to have hypoxemia, and it can even lead to infection. It can largely lead to low tissue perfusion. So that is why the infection aspects can come in. So we can have the vaso-occlusive crisis, and with the vaso-occlusive crisis, this patient will experience a great deal of pain. They experience a great deal of pain because their organs, their tissues, they'll be deprived of oxygenated blood because of the occlusion. So they can experience the pain at their back, they can experience the pain at the legs, at the knee, the arm, even their chest, or even their abdomen. They would experience a great deal of pain. So the vaso-occlusive crisis is one of the crises that a patient with sickle cell disease can experience. And another crisis that we can also talk about is the hemolytic crisis. The hemolytic crisis. Heme, blood. We are talking about the red blood cell. Lytic, breakdown. So hemolysis, the breakdown of the red blood cell. So the hemolytic crisis, we've talked about that already, that the abnormally shaped red blood cell is not so strong. It is very weak, so it breaks down easily. So patients with sickle cell disease can have the hemolytic crisis. That is the death of the red blood cell, the death of the red blood cell. And please, once the red blood cell is dying, the bone marrow would be prompted. So the bone marrow would make an attempt to produce more of these blood cells. So that is why we can have the increase in the reticulocytes. So I remember a question in S-Achieve, a select order apply question. SCD with VOC, what are some of the parameters, the trend? They can have an increase in reticulocytes, the immature red blood cell, because their red blood cells are breaking down. So the bone marrow will be prompted to produce red blood cell. And these red blood cells would be what? Will be mature. So that is why we are going to have an increase in the reticulocytes. In other words, you can have reticulocytosis. If the red blood cell breaks down, what do you think will be released? Please, if red blood cell breaks down, what do you think will be released? What is released when red blood cell breaks down? If red blood cell breaks down, what do you think it would release? Bilirubin, right? So bilirubin can be released when red blood cell breaks down. Bilirubin, naturally, bilirubin is yellow. It's yellow, right? And it is that natural yellow substance that forms when old red blood cells break down. So when old red blood cells break down, we said that bilirubin is yellow. So when red blood cell break down, it releases the bilirubin. So that is why it is very common that for us to see a patient with the sickle cell disease having jaundice. So the accumulation of the bilirubin would result in a jaundice because bilirubin is yellow. So the accumulation of the bilirubin will lead to the jaundice that they experience. So you can have an increase in the bilirubin. If the patient is having the hemolytic crisis, they can have an increase in the bilirubin. So that is one point that we need to also talk about. If they are breaking down their red blood, so do you think that the hemoglobin will go up or low? The hemoglobin will be low. Their HB will be low. So that is one thing that we need to talk about. Once the red blood cells are also breaking down, they are releasing what? Iron. About 70% of iron in the human body is stored in the red blood cell. So we say that the red blood cell loves iron. Iron is needed to make hemoglobin. Let's take note. Iron is needed to make hemoglobin. Now, about 70% of the iron in the body is stored in the red blood cell. So if the red blood cells are breaking down, it means that once they break down, they would also release iron. Yeah. So if you get a question about the trends. Patient who is experiencing hemolytic crisis, they would have an increase in reticulocytes, the bilirubin level would increase, the HB would decrease, and the serum iron would do what? It would increase. The serum iron would increase. So that is one key point that we need to talk about. This same bilirubin, ordinarily, the red blood cell will break down in 120 days. The bilirubin will be released. The liver will then put the bilirubin in the bowel. The bowel is stored in the gallbladder. So the bilirubin would come out of our body through the GIT. So the bilirubin would be excreted through our stool. It is this bilirubin that impacts the brown color to our stool. So that is how bilirubin gets out of our body, through the bowel. So the bowel serves as a transporter of the bilirubin. But over here, this patient is hemolyzing. They are breaking down a lot of red blood cells. So it becomes so much overwhelming. So their eye color will be so yellowish, they become jaundice and all. Even if they urinate, their urine will be dark because bilirubin, if it builds up, it can make your urine very dark, very dark. So that is why sickle cell patients, when they come, we usually give them the bottles. We can give them about 6 bottles, 10 bottles, depending on the level of the hemolysis. So we number it 1, 2, 3. So we tell the patient if you're going to urinate, so we call it the serial urine collection. So we do the serial urine collection. If we see that they are hemolyzing, we collect their urine sample. We tell them if you're going to urinate, pour some of your urine into bottle 1. The next urine or the next time that you're going to urinate, take bottle 2 and that. So you then compare the color of the urine, whether the patient is actively hemolyzing or the patient is getting better or the patient is responding to treatment. So the color of their urine can become dark, and it's as a result of the bilirubin. So that is one key thing that we need to talk about. So they can have the hemolytic crisis as well. And likewise, another crisis that they can also experience is that they can also experience what we call the aplastic crisis. The aplastic crisis. Aplastic. A means what? Absent. Absent or without. Absent or without. Plastic. If you trace the root word, plastic, the root word is plasia. Plasia means the growth or formation. Growth or formation. A, absent or without. So in aplastic crisis, we know what is happening. There is no formation or there is no growth. So the patient with sickle cell disease, they can have the aplastic crisis. And what happens in the aplastic crisis is that we are very much aware that it's the bone marrow that produces the blood cells. The bone marrow will become tired because the bone marrow would overwork. So in aplastic crisis, the red blood cell production comes to a stop, or it comes to a halt. So that is for the aplastic crisis. It comes to a stop or it comes to a halt. That is with the aplastic crisis. And please, let's take note. With the aplastic crisis in sickle cell disease, it is not so much common. But then one of the contributing factors to the aplastic crisis is the parvovirus. The parvovirus. Parvovirus. If an SCD patient is affected by this virus, the parvovirus can contribute to the aplastic crisis. Parvovirus. Please, which condition on the NCLEX is caused by the parvovirus? And the patient has a slap cheek. In that condition, the patient has a slap cheek. Which condition, Irons? Parvovirus. Parvovirus. Please, which condition comes to mind? The kill bank. They have a
Fig
they have a
disease.
slap.
Fig disease.
So if you go on the NCLEX and get a question, patient, the child, the cheek looks like we've slapped him or her, and they're asking of you of the condition, which you should know the condition. The fig disease, right? Fit disease. Fit disease. It says largely it can also be caused by the parvovirus. So the parvovirus can be a contributing to the development of the aplastic crisis, then please, aplastic crisis is very, 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 very bad. Even though the aplastic crisis is not common, we have what we call the aplastic anemia. So aplastic crisis can lead to aplastic anemia. And aplastic anemia is the worst form of anemia, aplastic anemia. So aplastic crisis can lead to aplastic anemia. We will not have the production of the red blood cell. So that is also another one crisis that sickle cell patients, they can experience. And the last of the crisis that we talk about is what we call the spleen, or what we call the splenic sequestration. The splenic sequestration, or what we call the spleen sequestration. So what happens, or what is the splenic sequestration? All right, what happens? With the splenic sequestration, it's very common in children as compared to the adults with the sickle cell disease, the splenic sequestration. We know the function of the spleen. The spleen plays a role in immune function, right? So the spleen has an immune role. The spleen forms part of the immune system, the spleen, the thymus, like they all form part. So what happens is that we are very much aware that the spleen it filters the blood. One of the functions of the spleen is filtering of the blood. The spleen can recognize and remove old and damaged red blood cells. It filters the blood. So it can recognize, it can identify old or malformed or damaged red blood cells from the body. And we realize that in the sickle cell disease, they are breaking down the red blood cell and faster, a lot more often. So the spleen would overwork. The spleen would continue to overwork. So once the spleen overworks, it will cause the spleen to become so much congested. The spleen would swell. It will become very big. So that is where we have the splenic sequestration. We can have the pool of red blood cell within the spleen, a pool of it within the spleen. And some of these abnormally shaped red blood cells can become trapped in the spleen. So as a result, it can cause the spleen to become so congested, and the spleen will swell. And as we said, the spleen has an immune role. So if the spleen is affected and the spleen playing or performing an immune role, it means that this patient will stand at a risk of infection. So that contributes to why sickle cell disease, we are so much careful about their infection, and the infection can trigger an episode of their crisis. So that is one key thing that we need to also look at. So with their crisis, the vaso-occlusive crisis, the hemolytic crisis, the aplastic crisis, and it can have the splenic sequestration. So this crisis, very, 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 very much important. We'll talk about the acute chest syndrome as we move on. So I want us to move quite faster. In fact, we'll be having a class from 4 to 6:30. So we need to finish on time and prepare for the class. So one of the key areas that we have to look at is the management, and can get quite a number of questions on the management. And the management, getting questions on the management is not so much difficult. So how would we manage a patient with a sickle cell disease? Our ninth mnemonic, HOPS. HOPS for H for what? Hydration. Hydration. O for oxygen. P for pain management. And we give support. We give support to our patients. So under sickle cell disease, under the management, we can remember this nice mnemonic, HOPS. Hydration, oxygen, pain management, and we give support to this individual. So please let me ask this. If you ever get a question in a Q bank, and the question is a prioritization question, between hydration and oxygen, which one would you choose? Which one is more priority? Patients with SCD, they are having a crisis. Of course, if they have the crisis, their SpO2 can drop. The SpO2 can drop. So oxygen is very, very much important. So between hydration and oxygen, RN, Seneca says oxygen. Please, who agree with RN? Hydration and oxygen, which one is a priority? Which one would we choose? Oxygen, hydration, 2 oxygen, 1 hydration. Hydration is
Hydration.
priority. It is not ABC. Works. ABC works, but please, let's not make it as a golden rule. There is no golden rule about the ABC. Hydration is a priority. So if you ever get that question, don't go in for oxygen. Oxygen is very important, but please, you ask yourself, they're having the vaso-occlusive crisis. They are having a vaso-occlusive crisis, right? Their SpO2 is dropping. What is causing their SpO2 to drop? What is causing the vaso-occlusive crisis? It is the sickled red blood cell that is occluding the blood vessel. It can be the hemolytic crisis. Their red blood cell is breaking down. It can make their SpO2 also drop. So hydration is very, very much important. If they are having the crisis, the vaso-occlusive crisis, because their blood vessel is blocked. So if the blood vessel is blocked and you're giving oxygen, what do you mean to achieve? The blood vessels are blocked with the sickle cell red blood cell, and you're giving oxygen. Yes, you are helping. You are delivering oxygen into the lungs. But what are you achieving? The problem is with the vaso-occlusive crisis, the blockage. So hydration is paramount. The hydration will dilute. So let me use the word dilute. Hydration will dilute the blood. In other words, the hydration would decrease the sickling or the sticking. So let's use the word the sticking. The hydration will decrease the sticking of the red blood cell. Once the hydration decreases the sticking of the red blood cell, of course, it is going to do a lot. It is going to allow the blood to flow through the blood vessel. It is also going to decrease the pain, because the pain that they experience, it is not the pain of a decreased oxygen. That is not the root, or that is not the main cause of the pain that they experience. The pain is caused by what? The blockage, the vaso-occlusive crisis. So that is why the hydration is very, very, very much important in this individual. So we go by the mnemonic hops. We hydrate the individual to decrease the sticking of the red blood cell. So hydration, very much important. We can't despite the benefits of oxygen. So oxygen is very much important. Depending on the SpO2, we will titrate the flow meter to the required flow rate. So the hydration can either do our IV hydration, or if the patient can swallow, we can tell them to take some water to stay hydrated. So that is one key thing that we need to establish. And what about our pain management? The pain management is also very much important. Pain management is very, very, very much important, because they can experience a great deal of pain. So patients with the sickle cell disease, we can do our pain management. And when it comes to the pain management, what comes to mind? It all depends on the level of pain, what the patient is presenting. So the healthcare provider can decide based on the pain assessment whether they are giving NSAIDs. They can even give paracetamol, or we can give opioids. So you see that we are giving the patient NSAIDs, we can even give paracetamol, or we can give the patient opioids. Let's put an asterisk on the opioids. We'll talk about one important fact about the opioids, especially in the kill bank. Common questions in the kill bank. So you can manage the patient's pain, which is very, 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 very much important in our discussion. But please, with the pain management, one key thing that we need to talk about is that we can give the patient the opioids, and usually the drug of choice when it comes to the opioid is the morphine, right? Morphine. The morphine is a drug of choice when it comes to the opioid, even though you can give your tramadol infusion and all of that. But then the morphine is usually a drug of choice when we are managing the sickle cell, the pain. So you can give them the opioid, can give them this pain medication, very much important. But when it comes to the opioids, pethidine, or what we call meperidine. So meperidine or pethidine, it is also an opioid. In sickle cell disease, in as much as possible, we avoid the administration of pethidine or meperidine. Please, why is it that it is generally not recommended to give pethidine or meperidine in sickle cell disease when they're having the crisis, when they're having the pain? Why is it that we don't encourage it? Why is it that we don't encourage the use of the meperidine in cases of the sickle cell disease if they're having the pain? Meperidine, the chat box. So let me go to the chat box. Yes, it can cause seizures. Exactly. It can cause seizures. the meperidine, if if it's metabolized in the body, it has a toxic metabolite called the normeperidine. It is called the normeperidine. Normeperidine is a toxic metabolite of meperidine. And if the normeperidine accumulates in the body, it can cause seizures. So the patient can have seizures. So that is why it is not recommended. So if a sickle cell patient has a history of seizures and all of that, please never think of giving this patient pethidine, because the accumulation of the normeperidine, which is a toxic metabolite of the meperidine, it can cause seizures. So that is why the use of the meperidine or the pethidine is not generally considered when we are managing the pain. The drug of choice in terms of the opioids is morphine, even though you can give your tramadol and the others. But meperidine, it's no. It can cause seizures, as Rn said. And this toxic metabolite can even impair renal function. It can impair the renal function. It can have a very bad effect on the kidneys, on the renal. So that is one key thing. So child with sickle cell disease and they're having a pain, and aside all the pain medication, also seeing meperidine, please, we're going for that. So we don't, it is generally not recommended. So that is one key thing that we need to talk about. So we've talked about the hops, the hydration, the oxygen, the pain, and the support. So as much as we are supporting them, if they're having a crisis, in as much as possible, we want to encourage bed rest. If they're having the crisis, they are in severe pain, we want to encourage bed rest, because if they engaging in activity will mean that the demand for oxygen would also increase. But already you're having crisis. Do you think that the demand for the oxygen will be able to meet? No, it would even worsen the crisis. So in the acute stage, or let's put it this way, when they're having a crisis, bed rest is recommended, but we need to monitor the respiratory status. Very, 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 very much important. We need to monitor the respiratory status. Why do we need to monitor the respiratory status? We need to look out for what we call the acute chest syndrome. Individuals with sickle cell disease, they can have what we call the acute chest syndrome. The same principle, the red blood cell that is in the shape of the sickle or the crescent shape, it can block the blood vessels in the lung. It can block the blood vessels in the lungs. If the blood vessels in the lungs are blocked, do you think we can have a smooth exchange of gases? No. So acute chest syndrome occurs when the sickled red blood cell blocks the blood vessels in the lungs. And acute chest syndrome, it's an emergency. In fact, acute chest syndrome is life-threatening. It is life-threatening. So that is one key thing that we need to look at. So that's why we are saying that their respiratory status, assessing their respiratory status is very, 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 very much important, because the sickled red blood cell can occlude the vaso-occlusive crisis in the pulmonary vasculature. It can cause the vaso-occlusive crisis. The patient can exhibit general signs and symptoms that are quite similar to pneumonia. So they can have fever, acute chest syndrome. So if you're managing a sickle cell patient and you see that they are having fever, in terms of their respiratory rate is also going up. The SpO2 is decreasing. They're having the shortness of breath, the SOB. They're having the chest pain. They cough. Then one condition or one complication that you can think of is acute chest syndrome. Fever, increase in respiratory rates, the SpO2 decreasing. They are having a shortness of breath, the cough, chest pain. Can think of acute chest syndrome. Let's notify the healthcare provider now, because acute chest syndrome is life-threatening. So that is why we are saying that monitoring the respiratory status is very, very, very much important. So that is one key thing that we need to talk about. And generally, as part of our management, we can transfuse the patient. We can give the patient blood. Sickle cell patient, they can be anemic, and we know where the anemia is coming from. So we can give the patient blood just to increase the tissue perfusion. We want to restore the blood volume, but largely we want to increase the tissue perfusion. So you can give the patient blood. You can do our blood transfusion. So on the blood transfusion, all the key NCLEX points about blood transfusion. Never get question wrong on blood transfusion on the NCLEX. Never get such questions wrong. So we can put the patient on the, so you can transfuse the patient. So that is one key thing. And clearly, a patient with a sickle cell disease, as part of the management, we don't apply cold compress. We've talked about this. Cold would do what? It will constrict. So we don't apply cold compress. It's a no-no. A patient should not wear constrictive clothing. It's a no-no. We don't want them to wear constrictive clothing. So if the patient is having a back pain, if they're having a back pain, and we are doing, let's say we are doing the opioid, we usually do it what we call around the clock. Around the clock means that when it is time for us to give the drug, we give it at the exact time, around the clock. We can try some non-pharmacological approach. We can do warm compress. You can put some warm compress at the back of the patient, or if it is a new pain, you can put some warm compress. So warm compress is good, but we don't want cold compress. Cold compress is a no-no for this individual because we know the effect of cold. So that is one key thing that we need to also look at. And you realize that we talked about the issues of or the problems or the complication that the patient with sickle cell disease that they can experience. And we talked about the fact that they can have the what we call the dactylitis, the digots. So the digots, dactylitis, itis, inflammation. So they can have dactylitis as well. They can have swelling of the fingers and toes, dactylitis. They can have swelling of their fingers and toes. This can be seen in a sickle cell patient. And what will bring about the swelling of the fingers and toes, aka the dactylitis? It is all about the sickled shaped red blood cell. The sickle shaped red blood cell will block the blood flow. And once it blocks the blood flow, once blood gets to our extremity and it gives the oxygen to our extremity, it needs to come back to the heart. It's so what we call the venous return. So you have to have venous return. But assuming the sickle-shaped red blood cell occlude or block the blood vessel, it will cause the extremity to become swollen. So that is one key thing. So if we have such patients, we usually elevate the extremity. We elevate the extremity. If their toes, if they are so swollen, we elevate. Why do we elevate? Elevation will promote what? Venous return. So that is why we elevate. So that is one key thing that we need to also look at. So that is one key. So that is about the management. So we address that issue as well. We've already talked about the anemia. That the anemia, we can give them, we can transfuse them, hemotransfusion. So generally, the anemia, we can do a complete blood count or a full blood count. The HB will be low. And we can even assess the patient. The patient would have an obvious sign of anemia. The patient would have an increase in heart rate, compensatory mechanism. The heart rate would increase. They'll have a shortness of breath. They'll have the general signs of anemia. We can even find out that they are pale. So we can transfuse them. But you can also give them some supplements. You can give them folic acid supplements. So we know the function of the folic acid. The folic acid helps in the maturity of the red blood cell. So you can give them the folic acid. But please, do you think that we'll give this patient iron? So we know that if a patient is anemic, we can give them iron supplements. But a patient with SCD, if they are anemic, would we want to give them iron supplements? Would we want to give them iron supplements?
No.
Iron supplements, SCD, a sickle cell patient? It's a no.
No, because they already have enough.
No. We don't. Why? Because if you realize, we said that about 70% of the iron in the body is stored in the red blood cell.
And it's broken down.
Patients with sickle cell disease, they are hemolyzing. The red blood cells are breaking down. When the red blood cells are breaking down, they are releasing iron. So that is why we earlier said that if they're hemolyzed, they can have an increase in the serum iron concentration. So the iron will be high. We know that we know that plenty of iron in the body is not good. We have what we call iron toxicity. Iron toxicity is there. Iron toxicity can affect a lot of the organs. Iron toxicity can affect your liver. It can affect the kidney. It can affect a number of organs in the body. So when the iron build up, so we call it the iron toxicity or there is a nice medical term for it. Hemochromatosis. So hemochromatosis is when the iron build up in the body to a harmful level. Hemochromatosis. So patients with sickle cell disease, that is why we don't give them iron supplements. Already, they have plenty iron in their body. Why? The red blood cells are breaking down. So we don't want to worsen it. So that is why we don't want to give them iron supplements. So please, let's take note. So iron can accumulate in the organs and it can cause a damage. So that is one key thing that we need to talk about. So as part of our management, clearly this patient will stand at a risk of infection because we talk about the spleen. The spleen can be affected. The spleen is not working so well. So we educate the patient to actually not expose themselves to individuals who are sick. And if possibly, they should take the vaccines, the annual vaccines, the annual influenza vaccine. They should take it. They should take the vaccines at least just to protect themselves from infection. Hand washing, they should do anything possible to prevent infection because infection can cause the sickle cell crisis. So with respect to the infection aspect, we'd also want to address that as part of our management. And largely, patients should avoid or should not get near individuals who have chronic illness or who have these communicable diseases. They shouldn't, and they should also take the vaccines. Very, 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 very much important. So that is one key thing that we need to also talk about. So largely, we talk about the medication as part of the management, and we would get to our final stage of ending. So as part of the issues that they experience, we said that a sickle cell patient can experience stroke. Why would they experience stroke? We know the two types of stroke, the hemorrhagic stroke and the ischemic stroke. So these are the two main types. We can also have the TIA, but then that is not the transient ischemic attack. We are looking at the two main, the hemorrhagic and that of the ischemic. Patients with the sickle cell disease, why can they have the stroke? The sickled red blood cell can block the blood vessel of the brain. Once the blood vessels of the brain is occluded by the sickle cell red blood cell, do you think that blood supply to the brain would be adequate? No. So the brain cells will be deprived of oxygen-rich blood as a result of the occlusion, and it can lead to an ischemic stroke. So patients with SCD, they can have a stroke. So that is what we said earlier. They can have a stroke. They can even have a problem with their eye. The same thing. The same thing. The same thing. The blood vessel of the eye. The blood vessel of the eye can. Please, kindly mute yourself, please. Aaron Abefi. Kindly mute yourself, please. Aaron Abefi.
Hello, so please, why don't you meet all of us
Please kindly
together?
mute yourself.
That's
I'm
the
finding it very
disturbance.
difficult to mute you. Okay, so let me mute enable. So I think I need to go to the settings or mute themselves. Okay, sure. So I think I need to. Okay, so they can also have problem with their eye. The same principle. The blood vessel that supplies the eye with oxygen-rich blood, it can be occluded. The same principle. They can have the leg ulcers. The same principle. So sickle cell disease, they can have a lot of issues. They can have a lot of issues. So that is what we talked about earlier. But as part of the management, we consider all of these. So question that would ask about how to prevent the crisis. We've talked about the cause of the crisis. So the opposite. If climbing high altitude, if dehydration, if exposure to cold, if infection brings about the crisis, then the prevention would be the opposite. So as part of the prevention, we want them to stay hydrated, plenty water. They shouldn't accumulate stress. So less stress. They shouldn't smoke, right? We talk about the effect of smoking. They shouldn't chronic alcohol or excessive intake of alcohol is not good. It can lead to dehydration and it can bring about their crisis. They can exercise, all right, but then they shouldn't over-exercise. So that is one key point. They can exercise, but then they shouldn't over-exercise. We know the effects of over-exercising. So they shouldn't over-exercise. So vigorous exercise is not good for this individual. So in terms of the prevention, all of this can come to mind. And the infection precautions or the infection aspect, the vaccine aspect would all come under the infection, would all come under the ways that we can prevent their crisis. So let's consider the medications, and we call it a day. So with the medications, we are very much aware of these medications. Patients who is having the who has the sickle cell disease, we usually put them on what? The hydroxyurea. The hydroxyurea. In fact, hydroxyurea falls under a class of drug. We call them the anti-metabolites. Anti-metabolites, hydroxyurea. Hydroxyurea can be considered as a cancer drug or a chemo drug. Hydroxyurea. So why is it that we give these drugs to individuals with the sickle cell disease? If it's considered as a chemo drug or cancer drug, why do we give this? Hydroxyurea. It is also an anti-metabolite. So hydroxyurea, the reason why we give the hydroxyurea is that research has proven that the hydroxyurea, once they take the hydroxyurea, it actually has an impact on their red blood cell. Sickle cell disease, they have an abnormal red blood cell, the hemoglobin, they have an abnormal hemoglobin, that is the hemoglobin S. Taking the hydroxyurea has an effect, a good effect on the abnormal hemoglobin. It makes that abnormal hemoglobin, it makes it mimic that of the fetal hemoglobin. We've established the fact that the fetal hemoglobin does not allow for easy cycling. It does not allow for easy cycling. So if they take the hydroxyurea, it makes their hemoglobin, the hemoglobin mimics that of the fetal hemoglobin. So the net effect is that if they are on the hydroxyurea, it decreases the chances of sickling. That is very good. Decrease the chances of the sickling means that it will decrease the chances of vessel occlusion. And largely it would reduce hospitalization. It would reduce hospitalization. And largely it would prolong their survival. It will prolong their survival. So hydroxyurea is good. Hydroxyurea, it decreases the sickling, it decreases the vessel occlusion, it will decrease the hospitalization, and largely it will prolong the survival. So that is why hydroxyurea, we put them on the hydroxyurea. But the most important thing is that hydroxyurea, as we said, it is a chemo drug. So one of the bad effects of the hydroxyurea is that the hydroxyurea can affect the white blood cell. It can decrease your white blood cell. It can decrease the white. We know the function of the white blood cell. White blood cell, that's what it fights against infection. So if the patient is on the hydroxyurea for a long time, it can cause neutropenia. It can decrease the white blood cell. Hydroxyurea can suppress the bone marrow as well. So the hydroxyurea has some bad effects. And if you are a female and you are on the hydroxyurea, we know the effects of the hydroxyurea on the fetus. Hydroxyurea is teratogenic. Teratogenic means that it is harmful to the fetus. So a female on hydroxyurea, it is very much important that they use a reliable birth control. Because if you get pregnant, this drug is teratogenic. It can harm or affect the fetus. The fetus can be born with some deformities. So that is one key thing that we need to talk about. So if you're a female, you want to stop, you want to have plans of getting pregnant, you have to talk to your healthcare provider. At least you have to stop the hydroxyurea for about 3 months before conception. About 3 months before conception, because the hydroxyurea has an effect on the fetus. It is teratogenic. So that is one drug that we give to patients or individuals with the sickle cell disease. But don't forget the bad effects of the hydroxyurea. And clearly, we also put them on the folic acid. We know why we put them on the folic acid. And we also put them on penicillin V. Penicillin V is an antibiotic, right? So we want it's a prophylactic treatment. We want to prevent infection. So that is why we put them on the penicillin V. So we put them on these medications. So these medications are very common in sickle cell patients. So that is one key thing that we also need to factor. Please, the last but one point that we want to say that we put across is that with a sickle cell patient, they are, especially those who don't manage it very well, they have the vaso-occlusive crisis, they have the hemolytic crisis and all of that. So they are mostly transfused. So transfusing this individual means that you can have a high of the iron overload. Hemotransfusion. So hemotransfusion can actually increase the iron overload, not just the hemotransfusion. In the sickle cell disease itself, they are hemolyzing, the iron is very high. So chronic or frequent transfusion, so let's use the word frequent transfusion can increase the iron level, the serum iron level, high, more than 500 microgram per ml, very lethal. It can cause iron toxicity. So that is, we also need to address that issue. So don't be surprised to come across those questions. Patients with SCD, they are receiving frequent transfusion. So what do you think will be the drug that we have to give to this patient to prevent the iron toxicity? What drug should we give, parents? What drug come to mind? This is a bonus question. Please let me unmute this. What drug comes to mind? We are transfusing the patient with SCD, frequent transfusion. We know that they can stand at a risk of iron toxicity or iron overload. So why don't we give a patient medication that will be able to decrease that chance of that iron buildup?
Is it Dexofamin or I don't know?
Deferoxamine.
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 Yes.
Right. Deferoxamine. Yeah. So some books you see deferoxerox or deferoxamine. So we give them the deferoxamine. So deferoxamine is a chelator. What is a chelator? It is a chelating agent or a chelator. A chelating agent are agents that are able to bind to heavy metal. So it binds to the heavy metal and it gets rid of the heavy metal out of the body. So iron is one of the heavy metals. So when we give our deferoxamine, the deferoxamine will bind to iron, not just iron, it can even bind to aluminum. It will bind to the iron and it will get the iron out of the body because we don't want too much of the iron. And transfusing the patient plenty or frequently, it put them at risk of iron toxicity. So that is why we think of giving the patient the deferoxamine. So please, let's take note of this. It is a chelating agent. And its whole rationale or its whole mechanism of action is to bind to the iron and get rid of the iron from the body so that you prevent the iron overload or the iron toxicity, the deferoxamine. One of the commonly questions on deferoxamine in the kill bands is the adverse effects. Deferoxamine, in as much as we're giving it, please, we watch out for what? Ototoxicity. So if you're giving deferoxamine to a patient and a patient says that, oh, I can't hear very well, please, we know that it is one of the adverse effects of the drug. So please, we need to notify the healthcare provider. So that is one key thing that we need to also look at. It's one of the adverse effects of the deferoxamine. Even though we have so many adverse effects, it can cause a fast heart rate. It can even cause a seizure. But the common ones in the kill bands is the ototoxicity. It can even cause a problem with vision. So this drug has some bad adverse effects. So that is one key thing that we need to talk about. So generally, patients with a sickle cell, in terms of their diet, we would encourage that they take a high caloric diet. They need high protein. High protein diet is good. And we can supplement their diet with folic acid. Or we can tell them to eat foods which are rich in folate, because we know that the synthetic form of the folate is the folic acid, and it is rich vitamin B, which vitamin? It's folate, all right, vitamin B9, right? So vitamin B9 is the folate, the synthetic one is the folic acid. So as we supplement their diet with the folic acid, you also encourage them take more of food that contains the vitamin B9, which is the folate, and largely folium, leaf. So those greeny leaf, they are very greeny vegetables. They are very rich in vitamin B9. So that can also be said as well. So generally, that is the overview of the sickle cell disease stroke the anemia. But largely, we've talked about the management in terms of their drug. These drugs will not cure the patient. These drugs that we talked about, the hydroxyurea, the folic acid, the penicillin B, it will not cure the patient. This is a genetic issue. This is a genetic issue. So the only treatment that usually aims at curing, but even with that, the success rate is not 100%. Is what we call the stem cell transplant. So you can do what we call the stem cell transplant, or we can call it the bone marrow transplant. The bone marrow transplant. Even with that, you need a donor. You need a donor. We also call it the hematopoietic cell transplant. The hematopoietic cell transplant. So you can do that, and that usually gives a brighter or a good prognosis. So we can also do that, but I believe it's quite expensive. It's quite expensive. So that is the overview of the sickle cell disease, stroke, the anemia. So key things, the crisis, don't forget the crisis. Don't forget what brings about the crisis. Don't also forget the management in terms of the HOPS, the HOPS, and also don't forget about the medications. So I don't know if there are some additions that we need to make. As I said, we have a class at 4 to 6:30. So we need to rush and prepare for the class. So please, can we add up on the sickle cell disease stroke, the anemia, before we call it a day? So as I said earlier, we are going to make an assessment available to us on the Telegram platform. Questions from the various skill banks on the sickle cell disease and the anemia. So let's try hands on the assessment. I believe the assessment will be able to. Oh, please, what is the blood transfusion of choice? Please, what is the blood transfusion of choice for a patient with a sickle cell anemia? Please, what is the blood transfusion of choice? We can do our whole blood, or we can do packed cells, right? So we can do the whole blood, we can do packed cells. So we have the various form of the various forms of the blood product. We have the whole blood, called the whole blood. The name, the whole blood. So the whole blood contains the plasma, contains the other cells, the red blood cell, the white blood cell, everything. Like everything is some whole blood. When you have just the packed cell, the red blood, so we've just isolated the red blood cell, so we can have the packed cells as well. And we have the platelets, so we can also have the platelet, but then this is not a bleeding issue. So once they're having a sickle cell anemia, we want the hemoglobin to go high. We want to increase the perfusion. So we can do our whole blood. We can do our packed cells, packed red blood cells. So that is one key thing. So as I said, all the key Nclex points about transfusion. Know if you are giving the patient the blood transfusion, know the time. We usually infuse the blood within 2 to 4 hours, right? If it goes about the 4 hours, the blood is said to be what? Contaminated. So that is one key point on the Nclex. And which infusion it's compatible with transfusion. Which one? Normal saline, right? Normal saline. So if you find a question in the LPN has hand Ringer's lactate alongside with the blood with the blood, know that no, it is a no. And the checks very, very much important prior to transfusion. And also how do you call it? If we are transfusing the patient rapidly, or if the patient is receiving rapid transfusion or frequent transfusion, the patient will need what they call a blood warmer. So some question asks about patient receiving multiple transfusion. Which device that the patient need, or which device would we need? We need a blood warmer. So that is one key thing that we need. So as we get a blood from the blood bank, and it's very, 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 very cold, we wouldn't want to put it down between the 20 to the 30 minutes. We need a blood warmer. So that is one key thing. And so questions on the blood transfusion, we need to do our grouping and cross-matching, very, very much important. So know the blood compatibilities, also very, very much important. And the RN has to stay by the patient the first 15 minutes, very much important, because we need the first 15 minutes. That is where the transfusion, if the transfusion reaction is to occur, you'll be able to identify within the first 15 minutes, and you stop the blood. Once you stop the blood, we put our normal saline. We don't throw the blood away in the bin. We send the blood to the blood bank alongside with the urine of the patient. why the urine of the patient may be having the hemolytic transfusion reaction. If they're having a hemolytic transfusion reaction, the lab technician will be able to examine the urine, and they'll be able to examine that you're having some red blood cells in the urine. So that is why the blood sample goes straight to the lab. The urine should also go straight to the lab. And if possible, we take the blood sample of the patient again, because it could be an error or a mistake once they were doing the grouping and the cross matching. So this point is very, very, very much important. And we notify the healthcare provider. So questions on the blood transfusion, not so much difficult. So that is one key thing that we need to also look at. I don't know if there is anything left that we need to talk about.
Nadia.
And as we said, within the 15 minutes, the blood transfusion, it runs slowly. Within the 15 minutes, very, very, very slow, at very slow rates. So after the first 15 minutes, if nothing occurs, then we just titrate, or we just open it according to the desired to run within the set time. So a lot of things should be taken into consideration. Yes, please.
Please, quick one. I didn't really follow because my network, I had closed from work, and in the car, the network was like muffling. So I just want to find out whether you really talked about the clothing of these patients, the things they wear. It's also important.
Yes, please. Yes, please.
Because you talked about the altitude and all that. So
yes, we talked about not wearing restrictive clothing.
okay.
So there should be
and apart from that, wearing things to cover themselves too as well.
Yes, so they should cover themselves, especially in the cold seasons.
Yeah, okay.
Yes,
thank
we don't want them to. All right, thank you very much. DSP,
I miss your voice, so yes, dear.
DSP, I salute you. Yes,
I think I both.
Can I add something small to the retinopathy?
Sure.
So
Yes,
as you rightly said, please can you hear me?
Yes, Aaron. Yes, we are here.
Am I audible? Okay, so
Yes,
with the sickle cell, clients with sickle cell disease, they do have some retinal changes. So they contribute to the retinopathy. So we have diabetic retinopathy, HPT retinopathy, and the sickle cell retinopathy. So usually you have to educate such clients to visit the ophthalmologist from 6 to 1 year, 6 months to 1 year review, so that they will detect any changes in the retina. Because these clients, usually the main problem is they usually bleed at the retina. And when this bleeding occurs for a long time, it can lead to retinal detachment. So they need to be observed like 6 months to 1 year review to check whether there is retinal changes, especially the vitreous hemorrhages. And with these hemorrhages, the major thing we do for them, we can do the laser treatment. So the laser treatment usually targets the unwanted blood vessels that grow at the retina, which causes the bleeding. So the laser will try to, burn these unwanted blood vessels, which causes the bleeding. So that's what the laser do. And sometimes we give anti-VEGFs. There are medications we inject into the eye so that it will help to shrink the abnormal blood cells so that it will prevent it from bleeding. And when it leads to retinal detachment to early treatment, the detachment has to be replaced. Other than that, you will lose the patient's eye. So our major concern is for you to advise them to seek, like they come to a continuous review, they visit the ophthalmologist so that when there is bleeding going on, it can be detected and these laser treatments can be done, or we can give them anti-VEGF, which can control the bleeding to prevent retinal detachment and subsequent leading to blindness also. So that's the little thing I wanted to add. Thank you.
Thank you very much, Aaron Akosia.
Hello.
Thank you very much for the solid points. Yes, please. Aaron.
Could the lady please spell out the drug she mentioned properly for us?
Hello.
The anti-VEGF.
Anti-VEGF. So the anti-VEGF is it's a broad name.
Asking you to spell it properly. Spell it for us, like.
We want the VEGF, we want the spelling. VEGF.
It's the anti-VEGF. Anti-VEGF. VEGF. But when we come to the medication under, we have different medication under anti-VEGF.
All I'm
We
saying
have
is
the
that could you please spell it
Avastin.
for us? The spelling
How
of
to
the
get
drug
the
you're
word?
mentioning.
So I'll go and look for it. Anti-VEGF.
Okay, I'll put it on the page for you. Please,
Okay.
I'll put it on.
All right. Okay. Ajia, please, in
Yes,
addition
please.
to what you said,
VEGF, VEGF, anti-VEGF.
Okay.
Anti.
VEGF.
So the VEGF, the VEGF is a mnemonic. The VEGF is the vascular endothelial growth factor.
Okay.
Vascular endothelial growth factor. They call it anti-VEGF. Vascular endothelial growth factor. So those medications will stop the growth of new blood vessels. Yeah, so that is the anti-VEGF. So please, it is just a mnemonic, priapism. Yeah, so I think with the SCD, the male, they can also have the priapism. The same thing. The same thing. They can also have the priapism as well. Pressure stain. Let's say the pressure stain is very, very, very much important. If they have a prolonged erection, we need to save it because some of these secondary red blood cells can block the flow of blood out of the penis. Let's take note of that one as well.
Yeah, your voice.
Okay. So please, we have just 7 minutes to begin.
So Hajia, last one. The teaching and education.
Class. So please, I don't know if there are some additions that we need to.
Hajia, last one. The teaching and education. Under the
time.
teaching and education, we could add the
Yes, please. Yes, please.
They should assess the sickle cell clinics. Because in my hospital, we have a sickle cell clinic. So they should assess sickle cell clinic in their area or community. Thank you. In terms of the teaching and education.
Thank you very much. Yeah, so they should. So usually most of these hospitals have the sickle cell clinic, just specially made for them. So as part of the teaching, they should visit the clinic from time to time. So we have a specially session for them. So Aaron, thank you very much. Some of Aaron, as you are some of the example of the anti-VEGF, commonly ones can have Avastin, AVASTIN. You can also have what's called the Lucentis, LUCENTIS. So these are all form parts of the VEGF. So please, thank you very much for your time. We shall make available the assessments on the Telegram platform with us so that we try and hands on it. But please, if you're not part of the Telegram platform, please, we would share the link. We will share the link with you so that you join the platform. The platform is a free platform, can have a lot of questions on the platform. Not just that, a lot of resources on the platform as well. So you share the link in the chat box, and we would have access to the Telegram platform as well. So just so let me get the link and share it. We have 4 minutes. Want to share the Telegram link with us? At least we're able to have access to the. Oh, please, can you hear me?
Yes, we can hear you now. Your network is muffled.
I think the network.
Yeah, we can hear you.
So please, I said that we want to make available the Telegram platform. Yeah, so we want to make available the Telegram platform and also the WhatsApp discussion platform in the chat box so that at least those of us who are not on the platform will be able to have access to the questions. So just a minute. So you can check the chat box and copy it from the chat box.
Ajia, there's a question. Somebody said, can it be treated locally?
Please, what do you want? Am I talking about the retinopathy?
A question in the chat box. The person said, can it be treated locally? I don't know whether sickle cell or whatever the person meant.
Or the retinopathy. So, please let me get this one. Sorry. Just a few. We have 3 minutes to the start of. Okay, please, let's have a look at. So please, let's get the link from the chat box. So this is the link. We can click on the link and join the various Telegram platform, different pages with a lot of resources. So we can. The first one is the Nclex-Rn platform, where we usually do the discussion, and you can find the NCLEX documents through the audio, quite a number of resources, the mnemonic materials as well, and the NCLEX procedures. And the WhatsApp platform, he'll actually make the WhatsApp platform available on the Telegram platform so that those of us who want to come on board will join. These are free platforms that you can join. So once again, you can join our private tuition, 4 months intensive tuition. We go through all the key NCLEX points. Irons, thank you very much for your time. We shall continue from here, God willing. Next week, we would also go through this other God willing next week, Friday. Thank you very much for your time and all the best in your studies. Yes, please. So please, the time for the class is 4 p.m. Yes, please. So we do 4 p.m. 4 to 6:30 p.m. most of our class. Thank you very much. Please, we shall continue from here, God willing, on our next meeting. God bless us all.
Hi, God bless you too, Mo.